Here, we will summarize and highlight Part 1 of the comprehensive updates regarding screening, diagnosis, and local treatment for clinically localized prostate cancer. Firstly, the relative risk of developing prostate cancer increases with family history, reaching a relative risk of 7.7 if two brothers are diagnosed. Germline testing should be considered in men with metastatic prostate cancer who are candidates for targeted treatment, men with BRCA mutations detected through somatic testing, men with multiple family members diagnosed with clinically significant prostate cancer before the age of 60, or with a family member who died from prostate cancer, or finally, men with a family history of high-risk germline mutations or multiple cancers on the same side of the family. Screening remains a highly controversial topic. However, the Rotterdam section of the European randomized study of screening for prostate cancer and the Gothenburg trial both showed improved survival in the screening arm, with the number needed to diagnose of approximately 10 to 14 to prevent one death. The current proposal is a 2-year interval for men at an increased risk, such as those with a PSA higher than 2, whilst it could be expanded up to 8 years for those not at an increased risk, i.e. patients with a PSA less than 1 nanogram per ml. Regarding diagnostic tools, multiparametric MRI and PSA density are important tools in the prediction of presence of clinically significant prostate cancer. To this end, based on a recent meta-analysis, a risk-adapted data table of clinically significant prostate cancer was developed, linking the PIRAD score and PSA density categories. Regarding staging of prostate cancer, on a local level, MRI findings rather than DRE to assess T-stage have shown to be better in predicting BCR-free survival due to improved discrimination and the associated stage shift. Whereas on a systemic level, at a per-patient-based analysis, the sensitivity and specificity of 68 gallium PSMA PET were 77% and 97% respectively after extended lymph node dissection at the time of radical prostatectomy. Hence, it is recommended in high risk and locally advanced disease and may be considered in intermediate prostate cancer. An important aspect which should not be overlooked is evaluating life expectancy and health status. Tools like the G8 screening tool, MiniCog, or Predict Prostate tool are recommended for assessing the suitability of patients for treatment based on their life expectancy and comorbidities. In localized prostate cancer, over 10-year life expectancy is needed for survival benefits from treatment. Men with significant comorbidities and with an estimated less than 10-year life expectancy, watchful waiting with symptom management is advised. Regarding active surveillance, the most common criteria includes low-risk disease with ISUP grade 1, less than CT2A, PSA less than 10 nanograms per ml, and a PSA density of less than 0.15. Moreover, also based on the findings from the recent PROTECT trial, one may consider to extend active surveillance to some patients with ISUP grade group 2 cancer. Regarding the implementation of active surveillance, adding MRI and targeted biopsies reduces active surveillance failures and reduces the risk of progression to ISUP grade group 2 cancers or higher at a 2-year follow-up. And the follow-up strategy is based on serial PSA at least once every 6 months, DRE and MRI at least once yearly, and includes standard repeat biopsy. However, several factors have been found to be associated with low reclassification rates and long progression-free survival. Therefore, in patients with a precise 3 score indicating stable disease on repeat MRI during active surveillance and a low PSA density have a very low rate of progression, and hence repeat biopsy may therefore be omitted. Regarding radical prostatectomy, preserving membranous urethral length during radical prostatectomy improves early return to continence. Studies show that every additional millimeter of urethral length seen on preoperative MRI is a significant predictor of continence recovery. Hence, preoperative MRI measurement of urethral length can help counsel patients on their likelihood of early postoperative continence. Next, extended pelvic lymph node dissection should be performed in patients with high-risk prostate cancer to guide further treatment, that being the addition of early ADT and/or pelvic radiotherapy. Regarding adjuvant treatment, for patients with undetectable postoperative PSA, adjuvant radiation and early salvage radiotherapy offer similar event-free survival rates. However, for those with adverse pathology, immediate adjuvant external beam radiation therapy after urinary recovery is recommended. On the other hand, between 5 and 20% of men have detectable PSA after radical prostatectomy. 74% will further experience PSA progression, with increased risk of metastasis and death. While the benefit of salvage radiotherapy in persistent PSA cases is not fully established, some studies suggest improved overall survival at 10 years with salvage radiotherapy. Hence, early aggressive multimodal therapy, potentially including ADT, may benefit these patients, but definitive recommendations await more more RCT data. Now, moving to definitive radiotherapy, dose-escalated intensity modulated radiotherapy or volumetric modulated arc therapy is the gold standard for external beam radiotherapy, aided by image-guided techniques such as gold markers or cone beam CT scan. Moreover, radiation increases the risk of secondary malignancies, but absolute risks are 1 to 4% over 10 years. However, this should be discussed, especially in younger men. Combining ADT with radiotherapy shows strong evidence for improved outcomes, including overall survival. For intermediate risk disease, 4 to 6 months of ADT is optimal, while 2 to 3 years is recommended for high-risk patients. Regarding schedule, hypofractionated radiotherapy, shown to be non-inferior to conventional fractions in trials like CHIP, offers similar efficacy with fewer treatments, and hence moderate hypofractionation with 60 Gray in 30 fraction has been recommended for practice. In high-risk localized prostate cancer, IMRT with or without a brachytherapy boost and long-term ADT of 2 to 3 years is recommended, while always considering patient comorbidities and performance status. Low-dose rate brachytherapy involves implanting radioactive seeds in the prostate and is suitable for favorable, intermediate-risk patients with good urinary functions. It offers up to 85% relapse-free survival at 10 years. However, urinary complications can occur, including retention, necessity of post-implant TURP, and incontinence. Erectile dysfunction develops in approximately 40% of patients after 3 to 5 years. Moreover, high-dose rate brachytherapy, often combined with EBRT, is used as a means to provide dose escalation for intermediate and high-risk prostate cancer. While quality of life changes are similar to high-dose EBRT alone, the combination shows superior outcomes, though definitive evidence from randomized trials is still needed. Finally, for locally advanced prostate cancer, retrospective studies of radical prostatectomy show over 60% cancer-specific survival at 15 years and over 75% overall survival at 10 years. Whereas for clinically node-positive disease, a systematic review of 5 studies suggests that combining local treatment, either radiotherapy or radical prostatectomy, with ADT provides better overall survival and cancer-specific survival than ADT alone. Moreover, further analysis indicate that intensifying systemic treatment with abiraterone acetate or docetaxel may benefit very high-risk localized or CN1 disease. Finally, a meta-analysis of approximately 2,000 patients showed that combining abiraterone acetate for 2 years with ADT given for 3 years and radiotherapy improved metastasis-free survival and overall survival with a hazard ratio of 0.6.